Okay, hey folks, we're going to have a little bit of a change in plans. So all the discussion that's going on around is really great, but if we could have people take a seat for a minute, and I'm going to actually put our innovators in the hot seat. So Drs. Mancini and Jeffries reminded me that best practices in innovation and simulation includes debriefing. And so we realized we hadn't built a debriefing into our session. So what we'd like to do is have the one innovator from each table come up to the front. We're going to put you in the hot seat. So we don't want the shy ones. We want the the ones that'll be able to face our masses, if you will. What we're going to do is we're going to open it up to questions from the audience before we go to the next session, and this will serve as a debriefing of what you thought was a pearl, what you thought was a pitfall, any general questions of our innovators, and it will help us start to think about our next session. As I remind you that each table is going to try and come up with a challenge or problem to solve using innovation. But I think the innovators, come on up. All you have to do is sit down. You're there, Angela. Oh, it doesn't matter. I don't think it matters. And the idea here is we really want the innovators we've invited to be able to get feedback from all of you. I think Dr. Mancini has the first question. So she will start to frame the questions. And do we have one of those handheld mics that we could bring up there to pass down? That might be helpful.
Do these work?
Yep, we're bringing a handheld mic up, and then so you either have to turn on the mic in front of you or make sure the mic you're using is turned on to capture all of this. And so, Dr. Mancini, I will turn the mic over to you for the first question.
Thank you, Eric. This morning, I don't think all of our innovators were here this morning to hear the morning presentations. No? No? Pam started us off by mentioning some of the major issues that we're facing in health professions education and how technology would be brought to bear. And I'm going to give you the 4 things she brought up and then ask you to perhaps feed back how you think your technology as an exemplar could address one or more of these issues. The first she brought up was faculty shortages. We have to come up with creative ways to deal with that. And so how much technology in general, your technology in specific, help us deal with that lack of access to expert faculty members. The movement to mastery learning, the importance, we know that educationally is important. How do you think technology is helping us to do that, if you want to address that one? Or also this idea of individualized education, targeted remediation. How might that be addressed, if you wanted to address that one? And then she brought up cost. And I'll just leave that one hanging, because some of you have things that are very expensive, some of you have things that are more open access, so you might want to speak to that. But with that idea of those 4 things, does anybody want to speak to what you think your product demonstrates as an example in a sentence or 2?
I'll try. So some of the things that we've tried to do with asynchronous simulation with the digital clinical experience in Shadow Health is directly for that faculty shortage. So if you're managing a class that has 40, 50, 100 students, even if you have a robust simulation lab, you're not able to monitor all of that. So some of the things we talked about with your colleagues as they came by was the transcript. Because we're conversation driven, we had that transcript, and then therefore that drives the documentation. And one of the most delightful aspects of our software for students is when they're done with the exam, they get to see an exemplar, which is a master nurse or a master educator who has gone through the simulation themselves and documented. So it's not a redlining exercise, but then the student gets to compare what their results were in documentation to an exemplar. So they get immediate access to that expert nurse, that expert faculty member at every simulation at 11 o'clock at night or whenever they. So that begins to address the faculty shortage. The next was.
One is fine, maybe pass it on. What do you think?
So I think mastery was interesting to me. So it's a complicated term, and in game-based learning, we usually sort of take an approach when we're trying to make a game that can express knowledge, we sort of usually break it down into 3 different paths. There's usually verbs, so games are really effective at creating a digital space where you can do something. Identity, games are really powerful at granting you a perspective and asking you to step into a role that maybe you haven't had before. And systems. Games are great at expressing rules that you interact with and master in order to get better at them. And I think, depending on your perspective on mastery, mastery is some combination of getting a particular set of knowledge in each of those 3 things in a complicated way, right? So a master of something will have a large list of verbs of things they're specifically good at. They'll have a long list of practices that they can do backwards and forwards. In terms of identity, a master will have a robust sense of not only what to do when they know what to do with those verbs, but they'll have a strong enough sense of identity empowerment to be able to wing it when they need to, right? So like mastery in terms of an empowered identity, I think is critical. And then finally, systems, understanding the context of information, how it all fits together. So the game I brought today is very focused specifically on practice, right? So we're just really focusing on the steps of CPR and saving a life. But I think with more robust game-based learning simulations and training, you can kind of get at mastery at a bunch of different angles. So, yeah.
I think our technology, the VSIM for nursing, is something that could be very well utilized for individual learning. With the instructor visibility to look at how the student is progressing and looking at the different areas where they are doing quite well on a regular basis and where they're really struggling. So from a faculty perspective, I'd be able to look at that and really focus my attention on those critical skills, those critical steps, those judgments, those decisions that are consistently not being done by the individual, while reinforcing where they are doing quite well, but being able to focus on where they need some help.
Yeah, so I would say our approach to helping out on some of those issues is to facilitate repeat consumption of the same content. So if you can get a diversity of, so again, we're RealDX, we focus on capturing the real patient experience. 700 cases in the library, and all of them are anchored by a 1 to 2 minute video that presents the case. So if you're wanting to develop mastery or develop a methodology that allows students to self-pace, you can assign them a group of these cases and allow them to review them as many times as they want. So repetition and diversity on clinical thinking is one way to build mastery, whether it's done individually or in a group setting. Let me also address the cost issue. Since you opened it up, I'll address it. Which is we worked with our early customers to find pricing that made sense to them. So our pricing delivers a faculty account for access to the entire library and use of the entire library for a year for about $200 per faculty member. It goes down with volume, and then for students, it's approximately the price of a textbook. So if you want students to have access to it, they don't get access to all the entire library. They only get access to what you assign them, and you can control what they see. They either pay for it themselves, $59 for the year, or the institution pays in advance for the students at $39 a year per student. So that's our pricing, which we think is affordable. Do you think that's affordable?
We looked at what we currently do and decided to say, can we do better? What we currently do is we teach too much, we learn too little, and we have a very fragile content retainment. We don't move short-term memory to long-term memory. and then we don't reinforce that memory to move somebody from competent to proficient to expert and make sure that they understand we value their time and their dedication. On the other hand, we've got faculty members who are just, getting killed because they got too much going on and too little time to do it. We remove the faculty person from the self-paced front end. They are very clear. It is not repetition, it's deliberative practice. I give them true, clear incentive. Your incentive is you go nowhere till you get this at 100%. You will continue to keep doing it until you get 100%. I don't care if you do it once or 2,000 times. It doesn't matter. It doesn't matter to the patient. You have to have the content knowledge to then be able to concentrate for a cognitive load process on learning the behavioral skill. We keep stretching the ability of the learner to understand concept as well as simultaneously learning eye-hand coordination and behavioral skills, et cetera. So this way, we're taking that away from that. We're making it a little easier. We're stripping down to a criteria based on the evidence-based practice as well as the content data of the JTTR. We're funded by Joint Program 6 and through the Institute of Surgical Research. So I'm free. That's a heck of a good deal. It's based on a unity base. This is something that will have to constantly, the reinvestment in it is you've got to have people, hopefully something like us, but to keep those JPC's content current, because don't teach old stuff when you've got the data to show there's something better out there. And so they're clear on their mission, they're clear what they have to do, the computer does all the work in between. And so I think we've kind of made that very clear using operational definitions and research data. That's it.
So I come at this at a little bit of a different approach because we're not currently selling into schools and into hospitals, but I think we definitely, look at the mastery learning as well as individualized learning, and an example of that is a nurse is scrubbed. This is a real case that we had. A nurse was scrubbed in for a procedure on a Friday. She was performing very poorly and she was very stressed out. She had this same surgeon she was working with the following week. And so the educator passed her the iPad and said, hey, take this home. Monday, you're going to be with the same surgeon all week. Practice, practice, practice. And when she showed up on Monday, she kicked butt. So she was great in the operating room. And, so that's an example of the individualization. The example on the mastery learning perspective, so I mentioned before that the best nurses anticipate before, the surgeon asks for something, and our scoring system, the way it's built in is that, it takes, and this is what our research shows, it takes 7 iterations on a procedure to get to that mastery level and to begin anticipating. And so, we don't enforce it yet, so I like the idea of enforcing it, and it's reminding me of some of the progression that we put in video games. And so it's something that I think will be very important moving forward. And then I'll touch quickly on the cost. We always take a look at what it's costing to do something today before we put together our pricing, and so that was a really big thing, and we wanted to save money when we priced and we put together our pricing packages.
Okay, last again. I'm going to take these in a different order. I think healthcare education has to truly transform and embrace rigorous assessment, period. 80% proficient on a skill like endotracheal intubation is great if killing 2 out of 10 is okay. We have to really, within our own groups themselves, start to promote and push this concept of mastery learning as the model by the time you're ready to enter clinical practice. Maybe it's not the model in early learning. There are plenty of other things that work and work well there. But I think as organizations and groups, we have to really embrace that we have got to get very serious about rigorous assessment. That means we have to really understand what expertise looks like, and that's measurement. That's my interest. I want to see what expertise looks like. I want to break it down in hierarchical task analyses and dissect it to a granular level so that I can digitize it, because I could digitize you a faculty extender. right? And we've heard about a lot of neat technologies that are faculty extenders. So that's how we start to address the problem of decreasing number of faculty, or faculty that may not have as much experience as senior faculty move up in administrative roles or move on to other bright horizons. But I think the first commitment is really settling ourselves on the idea that assessment is very important, and we need to be serious about it, and we need to be methodical about our approaches, and we need to adopt some different approaches to it. And I think a lot of these technologies can provide tremendous amount of insight into developing a portfolio of performance about an individual versus these data points, right? Saying that you can intubate great, error-free performance over time, because in the mastery learning model suggests is great, but if you can't assess the patient, then did it matter, right? So portfolios of assessment at high levels of rigor are going to be important. And then we look at how do we employ all of these different and unique technologies to really approach that. That leads to the next thing, which is precision education, right? If we have these commitments to assessment, we have the technologies that allow us to assess so many different aspects of their knowledge, their psychomotor skill, their attitudes and behaviors, and develop a portfolio of performance about a learner. Now we're getting to precision education, because every learner is going to have their own genetic code of needs. But these systems will allow them to, with machine learning, to identify those needs and better prepare each individual student, giving them the time they need to do these things. So it's going to cost a lot, but it's the first student that costs a lot, right? The second student is half the price. The third student is a third. You get the idea. So by the time we democratize this across all the different health professions and all the different learners and all the different professionals in practice that would probably benefit from these same systems, it's a small cost.
Thank you, panel. So I'm told that we have time for one or two burning questions. So table 5, you have a burning question? Yes. Can someone hand her a microphone or use the microphone? Thank you.
Here. When we've tried to implement a lot of the kind of thing you're doing in the Department of Defense, our big problem has been faculty development and how to get faculty to be able to understand this well enough to use the technology and the great kinds of things you have. So could you just address the faculty development issues and how it is that we really maximize what many of us know is possible, but challenge?
Probably have time for one panelist to tackle that, and then we're going to go on break, and you can corner the panelists all you want during break. So go ahead, Dr. Parati.
Okay, let me just answer this from perspective of 26 years in the Navy. Right now, we are heavily burdened with also a lot of what I call admin work that takes time away from the student. And so if any of these systems also can help support the documentation, because Jeff's right, we've got to be able to keep records and be able to not only assess our learners but assess our own programs to see where we could do better. That will make a difference. The other thing is the leadership also needs to take a strong role in saying you have permission to be creative here. I mean, we have a history within DoD where an idea of teaching a course is reading verbatim from a text. And so we have some innovative instructors, and then we have an old vestige that I think is long overdue to move forward. And we also have to put the emphasis on not just considering simulation or return demonstration as I show you one and you do one and you're good to go and you got the check in the box. We really, as Jeff was saying, we got to get serious here and say, can you really do what we're asking you to do? And if not, are there other mechanisms that we then need to start employing that we haven't captured yet? It's a perspective for those people who are dedicated to teach, but again, if they know they're teaching people who really want to learn, it also helps a great deal.
So I want everybody that wants to get a chance to use the bathrooms and to stretch and wiggle around to do it. But I would encourage you, assuming the panelists will be gracious enough to continue to entertain discussion during the break, to please engage with them or continue the great discussions I've been seeing around the room at the break. But we do want to be mindful that some people have biological needs. What's that? 3:15. So we'll be back at 3:15, and I know everybody here is as passionate about innovation as I am and all these innovators. So please carry on the great conversations. Thank you.